We're going to start with a interlaminar injection using the Biotross model. So let's say this patient has a 4-5 fusion like this one does, and they're having some breakdown at L5-S1. We want to get some medicine in the epidural space at L5-S1. Sometimes it can be very difficult with these fusions and with the rods to do the injection around the screw, so I like to go interlaminar a lot. So to set up an interlaminar injection, and one thing I really stress upon is using Dr. Furman's textbook. I think you've read it and you've looked at it as well for these injections. It really shows really nice setup. But you can't just go by the textbook all the time, exactly where the C-arm is supposed to be. People say, oh, it's 15 degrees this way, 15 degrees this way. No, it's based on the patient's anatomy, right? You have scoliosis, you have some rotational scoliosis, side scoliosis. Everyone's a little different. So you have to know how to set up this space to get in and set yourself up for success. Every resident, every fellow that we teach, I tell them, most important thing is the setup. Anyone can put the needle. I can tell you, if you've never touched the needle before, I can pull someone off the street and say, hey, put a needle here. And eventually you could get it there, right? It's putting the needle in the right place. So that's diagnosing in the office before you even get in the procedure room. Knowing how to look at the MRI, that's part of diagnosing. Knowing how to talk to a patient, getting their HPI, that's part of diagnosing. And then finally, it's putting the needle in the right place. And before you can even put it there, you got to get the right imaging. So we're in a straight AP view right now. So what does that mean? It means we're looking straight anterior, posterior, using the C-arm. We're going to tilt a little bit towards the feet. That's going to open up that interlaminar space at L5-S1. Perfect. And that L5-S1 space, I'm going to walk over here and show people, is this space right in here that we're looking for. So this is the L4-5 space. So we have the spinous process. These are the fusion screws at the L4-5. This is L3, L2, L1. This is L5. This is our pelvis coming around, which always can make things difficult when we're going to L5 or S1 for kyphoplasties or intracept or transforaminal injections. So the space we're aiming for is right here. I don't like to go right down the middle because you have the interspinous ligament there, so it can be a little tough. So either go on the left or the right side, but we always end up in the middle. Usually I'll ask the patient what side is their pain on more. So if it's on the left side more, I'll start on the left. Usually we end up in the middle though, and 95% of the time the pain spreads to both sides. So I'll start, we'll just use this as a pointer to start. I'll start and do the first one, and then both of you will do one, and we'll see how we go. So shot. So a lot of times what I'll do, one more shot, is oblique a little bit towards me since we're going to come from the left. Just 5 degrees possibly. Give me that exact angle I want to come in. Shot again. Especially when you're starting. So that's going to be our starting point. So what do we normally do if this is a real patient? We numb this up with some lidocaine, give it a few seconds to numb up, and then we proceed with the epidural needle. But since this is a Biotross, we can go right for it. Shot. So like I said, you want that needle to look as much as a dot as you can. That means you're on beam. My fellowship director used to always yell at us, get on beam, get on beam. That means you're going the way you want to go, the way you have the setup. And if you set up the setup, all you got to do is make that a dot. That's what we call it. So why is it a dot? If you're looking straight down or on beam, it's going to look like a perfect dot, right? So you don't want to be off angle or off axis, and that's going to give you a better idea of where you're going. So we're going to aim, we're coming from the left a little bit, aiming for the middle, keep going down. So what's the problem? And this is, I'm going to quiz you guys a little bit, it's going to be hardcore. What's the problem with only looking at one view? What don't I know? A deep aim, right? So what do I need for that? I need a second view. So once we get close to where we think we are based on the patient's depth, looking at their MRI beforehand, we're going to put that on the right side because we want to use this image still. And we're going to go, sometimes you go lateral, a lot of people will go contralateral oblique. And that's what we do, is we go contralateral oblique, which is about 45 degrees right there. That's perfect. And that's perfect. So lock that in there, Linda. Linda's our x-ray tech today. So I'm going to come back over here and explain a few things. I'll use this as my pointer over here. So this is our needle coming in at the L5-S1 space. This is the ligament. There's a ligament here, the ligamentum flavum, that we need to pop through in order to get to the epidural space. And you're going to have a loss of resistance when you get through that space. We call this the Interlaminar Line. And that's you can only see this in the contralateral oblique view. That's your stop sign. So I'm pretty close. I knew I was almost there just based on how big the patient was. Over here is our AP view where we have the dot, and we know we're going from left side to medial. So we know this is going left to medial. We have about, I'd say, ½ an inch left to go. So we're going to slowly bring this down to the interlaminar line. Feel that resistance of the ligamentum flavum, and then we're going to go in with the loss of resistance and pop into the epidural space. Shot. See how we're bringing it millimeter by millimeter. Shot. What happens if you go too fast, go through the ligament inflatum, and what then go through the epidural space? What's next? What's after the epidural space? Dura. And what happens if you get into the dura? Lumbar puncture, right? And you're going to have spinal leak, CSF leak, patient may get a headache. Now, not doomsday, but bad is if you inject into the intrathecal space. You definitely don't want to do that, especially with some Marcaine and some steroids. It's not the end of the world, but you're going to make the patient totally numb, could cause power bladder issues, could cause a cauda type syndrome. So that's also why we use contrast to make sure we're not in the dural space. If you inject in the dural space, I always say there's 5 checks you do whatever injection, right? First check is your imaging. Second check is your loss of resistance. So now we're going to do that. So we should have some good resistance here. See how this is bouncing up and down? I don't know if we can zoom in on that, but see how this is bouncing up and down? That means there's resistance there. When I get into that epidural space, shot, this will eventually give way. Shot. Getting close. Right there. See how that gave way? That means I'm in the epidural space. Shot. So that's my second check, is loss of resistance. What's our third check? We put contrast in. We're going to see there's a difference in contrast pattern, and you've seen me do live injections. There's a difference in contrast pattern between an epidural contrast and an intrathecal contrast. Epidural contrast, you're going to see that epidural fat. We call it the bubbles, right? So you see outlines of the epidural fat. That's how you know the epidural space. In the intrathecal space, you'll see this motion, and you can go live with it. That's actually my fourth check, is when we go live. You'll see this motion of the CSF. It's not really with the heartbeat, but it can look like it's a motion of the heartbeat. In the epidural space, the contrast should stay steady. So we've done 1 check, image, 2 check, loss resistance. 3rd check, we're going to come and take an AP image. So we're going to make believe the contrast is in there. We don't want to put a bunch of contrast in here because we want to keep using this model, and contrast will just muddy the pictures. So right where we want to be, this is where you'd see that nice epidural fat, epidurogram we call it, instead of seeing the intrathecal spread. So that's 3 checks. 4th check is watch for CSF fluid coming out. If CSF fluid's coming out, then you know you're too deep. And that 5th check is when I go live to look at that intrathecal space. So we're good. Patient's doing great. Patient's awake. We're at, and the 6th check that I like, and this is why we keep our patients awake, is if you're in the wrong spot, the patient will have severe pain. The patient should not have much pain with these injections other than some pressure and a little bit of the needle poke. They shouldn't have severe pain down their legs. It should not hurt them that much. You're either going too fast or you're in the wrong spot. You're on the nerve root, something along those lines. So that's my 6th check, because I keep my patients awake for these procedures, which I think everyone really should. So then, from here, the rest of the injection's easy. You put in the medicine. For an interlaminar, I use 2 cc's of Dex, 3 to 4 cc's of 0.25% Marcaine, and 3 to 4 cc's of saline. Why do I do that? I want good volume spread here. We're not looking for a selective nerve root block. This isn't that diagnostic with these injections, right? This patient's had an L4-5 fusion. They're having pain. We're looking to knock out their pain here. We're looking not to do another fusion. So that's pretty simple. So we come on out after we put the medicine in, and we're good to go. So who wants to take a crack at it first?